Evening, everybody. So evening to everybody that's joined me for the live stream, and welcome to any that are on the replay crew. Great to have you here. So today I'm going to be talking about inhalers and asthma and COPD and any other condition that you might use inhalers for, and all the different types of inhalers, and why it's important to ensure that you know which ones to use in which circumstances and how to get the best out of them. So I will have a look through the comments and do a quick welcome before I start on my disclaimers. So welcome to Neil Keita, Carl and Demi. So I've fetched my inhalers along with me so that I can show you how best to use these. But yes, this is your reminder to make sure that you've got your medication, that you've ordered your medication, and that you can remember to take it each and every day. So, hello Nightbot, and hello Mum and Dad. So great to have you all here. I'm going to run through my disclaimers so that I get all of that out of the way. So this information is for educational and entertainment purposes only. Although I am a pharmacist of 20 plus years, it is always best if you actually talk to your own healthcare provider about your own unique situation rather than just taking advice off some random person on the internet. And also I am based in the UK, so I will be talking about the inhalers that are available in the UK, and they are different in different parts of the world. So bear that in mind. And I'll go through my YouTube. If you can like the stream, it will help share this stream out to more people, so I can provide some advice for people around their inhalers. And if you'd like to subscribe to my channel, that would really help me. I'm trying to build up to that 1,000 subscribers. And I appreciate any watch time that you can give me. I've got quite a lot of videos up. I think this is my 21st live stream that I've done. I've done quite a lot of different subjects, blood pressure, blood thinners, diabetes, weight loss, skincare. So there's all of them that you can go back and look at. And you can also send me requests for future live streams on any subject you'd like to talk about. I've also done quite a lot of standalone videos, including one about inhalers and why asthma still kills. My last one was on proton pump inhibitors, and I think I've now got 18 of those videos. And my next one, which seems to be taking me a long time to do, is on magnesium, but I've increased my hours at work, and I'm now stepped up into a higher position. So that's taken a lot of my mental energy at the moment, which is why I've not put together as much on these videos. Plus, I've also been trying to look after my own health after being diagnosed with adult onset asthma. And so I have been going swimming and to the gym. So trying to get my cardiovascular health up and my lung health, so that I can be in the healthiest that I can with the conditions that I have. Okay, so Demi says, I don't know anything about inhalers and very little about asthma or COPD, so this will be interesting for me. Yes, I was going to say, even if you don't actually have asthma or COPD yourself, it is very useful to know the basics about inhalers so that you can actually help in an emergency situation, and also be respectful of friends and family that are struggling to breathe and what you can do to help them. And Cal says the opposite. Indeed. Oh no, indeed, all I know about inhalers is I need one nearly every winter. Okay, well, if we can try and make sure that when you are needing it, over the winter that it does the best for you. So hopefully I can provide you with some insight on that. So, and hello, Mr. Angel Ab, great to have you here again as well. Okay, so now, Keita, I can't find my inhaler. You have the blue one. So I'm assuming you're meaning you've got one of these. And I'm hoping the fact that you can't find it because you hardly ever need to use it. However, it is always best if you've got asthma to always know where your blue inhaler is. Make sure that you're carrying it around with you all the time, because you never know when you're actually going to need that. So let me. Okay, that's nice, but busy thing. Right. So I'm going to just cover that there's 4 different types of ingredients that are in inhalers, and things actually now get more complicated because for each of the type of ingredients, there's 3 or 4 different sister drugs in that group. And when it comes to actually the inhaler devices, there's lots of different inhaler devices. And now we've actually got combination inhalers. We've had dual combination inhalers with 2 ingredients in for a long time, but we now have, over the last couple of years, had some inhalers that actually have 3 ingredients in. One's called Trelegy and one's called Trimbo. And that obviously we're using the tri as in the Latin for 3. Hi, Sam. Great to have you on here as well. So now Keita says, yep, the blue one with the dark lid. And yeah, I never really need it. I had it the last time I went to surgery, but after that, where I put it, I don't know, who knows. And that is the problem, trying to keep it nearby. If you're not actually needing it very often, it can be hard to find. So my blue inhaler, I never, ever had problems with my breathing the whole of my life. Nothing wrong with my lungs. I caught COVID a couple of times, and then I had another virus that was supposedly COVID negative, but it left me with a wheeze and struggling to breathe. And I ended up seeing my doctor, who ran every test under the sun, ended up seeing the nurse who asthma nurse who went through all the peak flow and started me on one of these inhalers, and it seemed to respond. So here I am with adult onset asthma. Now, I'm not going to go much over the actual diagnosis of asthma or COPD because that isn't my forte. That is for the doctors and nurses. The main difference between asthma and COPD is usually asthma starts earlier on in life for the majority of people, but now there is this subset of people called adult onset asthma that are struggling because something's caused a problem with their lungs. A lot of people with asthma also struggle with allergies, and that can be allergies as in hay fever that can affect the breathing, but it can also be allergies as in skin allergies with eczema, and it can also be with anaphylactic allergies to foods. So there is a link there because it is to do with an overactive inflammation, overactive immune response that can cause problems with asthma. The main way of telling the difference between asthma and COPD is that asthma is known as a reversible airways disease, whereas COPD, or chronic obstructive pulmonary disease, is known as a non-reversible airway disease. And the test for that is using a blue reliever inhaler, which contains either salbutamol, terbertulin, or albuterol if you're in America. I never realized that until people in America start saying they were taking albuterol. It's not one that we've ever had in the UK. And the difference in the testing between asthma and COPD is with somebody with asthma and they're struggling to breathe, when they do the tests of their lung function. So either a lung function test or even a peak flow where they just blow and see how much they can blow out. By taking one of these inhalers within half an hour, that's significantly improved. Whereas somebody with COPD, taking one of these inhalers doesn't really provide much benefit. And historically, they used to prescribe these inhalers to people with COPD. They used to be taking 2 puffs of them 4 times a day and not actually getting all that much benefit from it, because they're actually needing something that's longer acting and deeper acting. Oh, sorry. I'm throwing my screens on that. So Cal says, the type of inhaler I would usually be given for the extreme bronchitis are apparently called turbohalers. Don't know the name of the product though, as well as one of those round ones. Right. Yeah. So when it comes to types of inhalers, these ones are known as metered dose inhalers, and they work by having a pressurized canister inside of them. And an easy trick, if you do have any one of these and you don't know whether you're picking up an old one and you're not sure whether it's full or not, if you actually put it between your thumb and your finger, you can actually shake it just a little bit, and if it's still fairly full, you will actually feel the liquid hitting against the end of it at your finger. Whereas once it's empty, you don't actually feel anything in it, the propellant's coming out, because even once your dose is finished, sometimes pressing it, you will still see the air coming out. Now, this is the one that you would most commonly see for most people with asthma, because it provides, you don't actually need to have much of a suck to be able to pull it in, because it actually gets sent out with a puff. Now, a lot of people with these, the majority of people with these really, really struggle with the coordination to do this. And this is no disrespect to anybody who takes one of these and struggles with it. It is hard for the majority of people, especially when you're actually having problems with your breathing. So a lot of times you'll see that these often have been given for children with asthma, and sometimes they even have, instead of it being a mouthpiece here, it's actually a mask, and that can be really helpful for when children are having an asthma attack and you're trying to get them to actually breathe in an inhaler where they've got zero coordination. But I do actually recommend for any adults that have got an MDI to actually use one of these, because it massively improves the amount of the medication that actually gets into the base of the lungs, and it saves that stress. Also, when it comes to having a steroid inhaler, it also stops some of the side effects that you can have in the mouth. So, going all over the place with this. So, as you can see, when you take one of these, and I'm hoping that this actually might show better on this one because it looks better. I'm going to see if I can get it to show. So, hoping this will work. So when you actually press it, no, I didn't really show. I might have to actually do it. I might have to just waste one of my doses. But when you actually spray it, it does actually come out about 60 miles an hour. Yeah, so it just squirts up over there. Absolutely massive. And so if you've not actually got the coordination when you're breathing, it can actually just hit the back of your neck, hit your back of your throat. Quite a lot of people find as it hits the back of the throat, it causes a bit of coughing, which obviously means it's not going to get into the bottom. So, yeah, that's what I'm just saying. It is very hard when you're having an asthma attack. And I know it is clumpy to carry one of these around, but it can be much better because it saves that sort of frustration during an asthma attack of trying to get it in, just being able to breathe slower through one of these. So the way that you would, right, I'll do the two methods. So the first method is somebody who's using one of these who hasn't got anything else. Now, what you're trying to do is getting it to the base of your lungs. So the best thing to do for all inhalers, including these, including the dry powders, including the turbo inhalers, is that you'll need to be doing some normal breathing and then doing one really long breath out to try and empty your lungs as much as possible. And then you'll be wanting to place the inhaler over your mouth, sealing your mouth around the whole of the end of the inhaler, so it's fully sealed. And then you want to start breathing in, and then as you start breathing in, you press the button down, and then you carry on breathing in nice and steady. You don't need to do a really deep hush. You just need to just carry on breathing in. It's actually forcing itself through, so you just need to carry on breathing in, and you breathe in as much as you can over about 4 seconds. So nice deep breath in, sort of 1, 2, 3, 4, and then hold it for as long as is comfortable. Obviously, while you've got an asthma attack going on, that is not going to be comfortable. So you just got to do your best, and then try and just breathe out slowly. So it's place in, press, then hold, and then just carry on breathing normally as you can. And if you're just taking inhalers during your twice a day, leave 1 or 2 minutes between taking a second or third dose. Obviously, if you are in the middle of the asthma attack, you can actually take a second dose, a third dose, a fourth dose over sort of the following few minutes, and you can sort of have a shorter gap for that. Although, obviously, with children, then you would have it in the end, you would press the button, and then you would just it holds it safely in here. It hasn't hit the back of your throat. It's in suspended animation in there. So you can take your time. It's not going anywhere. And then you can just breathe normally and hold it in. So you can do a slower breath because it has been held there. In fact, you actually do need to do a slow breath. It will actually tell you off if you're going too fast, because if you're going too fast, it whistles, and that means that you've actually done it too fast. So, and then it's the same with the what we call dry powder inhalers. I'm going to see if I can present my screen. So I'm just going to show on here. There's lots of different types of devices that have little dosages on them to say how many is left in them, and there's a whole different host of them. Obviously, I haven't got dummy inhalers for all of these, but if you are struggling with any device that you have been given, I would really recommend booking an appointment to either go back and see your asthma nurse, or going and booking in to see your pharmacist at your local pharmacy, or at your GP practice if they have one, to go over your inhaler technique with them. A lot of the devices, some of the devices come where you've actually got to put the device together or put a refill in the device. They usually come with instructions in it, which can be quite wordy and quite hard to look at. But all of the companies do tend to have YouTube videos where they will actually show you how to actually do it on a YouTube videos. So, hi, Tanya. Right, so, okay, so Cal said the middle and the second and the middle last rows are the ones that you have almost every winter. Right, so I'm going to actually go back through what the different drugs are in them. So, I've gone about the emergency reliever inhalers. So they are salbutamol, terbutaline, and albuterol. So these are beta agonists, and they work by acting on beta receptors in the lungs that open up the lungs. Now, last time, 3 weeks ago, we talked about blood pressure medicines, and we mentioned beta blockers, such as your propranolol or atenolol, that used to lower blood pressure. And I explained how they're acting on sort of your sympathetic nervous system, which is your nervous system that gets activated when you are in a fight or flight situation. And when cortisol and adrenaline is going around your body, and the beta blockers block that from working. Whereas actually these are the beta agonists, and an agonist means it activates. So these actually activate the receptors that allow for your fight or flight. And part of your fight or flight response is to be able to open up your lungs so that you can breathe more to allow more oxygen in. So that's how it works. So it relaxes your lungs so that they can open, expand more, allow more oxygen in, so that you can oxygenate your blood more, and obviously then either fight or flight when you've got sort of the threat there. Unfortunately, that it then does come with side effects, and although you are putting this directly into your lungs, so the majority of the drug is acting actually just on the lungs. There is a little bit that does get absorbed into your bloodstream because of the sort of the mode of action. It's allowing you to breathe more. It is allowing you to expand your lungs more. And this particularly happens if you were to use this. So in an emergency, you are actually allowed up to 12 sprays of this, of which I would, if somebody's requiring up to 12 sprays, I would recommend doing it via a aero chamber, one after the other, breathing. But it can then have the side effect of the same of having excess cortisol and adrenaline going around in your body. So one of the side effects from that is that you can then get the shakes, and the other side effect is that you can get a racing heart rate. So that is something to bear in mind, because what happens is somebody's had an asthma attack, but then they take their beta blocker and they've got anxiety from having the asthma attack, and then the beta agonist can then actually add to that anxiety when it's starting to cause tremors and tachycardia, and it can seem to make things worse because you're adding on them anxiety side effects there. So we do try and sort of be aware of that it even though it's opening up your airways, you are sort of opening up, and you do need to sort of just be aware that that's going to be the side effect. Now, there has been a big look into the overuse of these. Now, this is an absolute life-saving medication for the majority of people with asthma. And in an asthma attack, it is the thing that will stop the asthma attack. Well, it'll help allow oxygen into your blood while having the asthma attack. However, it does nothing to actually help or solve the asthma. The asthma itself is due to underlying inflammation and allergies within the actual lung tissue. And although this might help open up the lung tissue, it's not actually making the lung tissue be any better. So I've actually found that people that use too much of these blue inhalers, that is a sign that their asthma is not very well controlled, and that they're actually at higher risk of dying from a future asthma attack, which is what my previous video was an analysis of the Why Asthma Still Kills report, which looked at all of the asthma deaths in the UK over a 2-year period, which was 10 years ago. It was back in sort of 2011, 2012, and they looked at all of the asthma deaths that occurred. They didn't ignore any, they didn't try and discount any, they looked at all of them. And one of the most common factors in there was that everybody that was on there had actually ordered lots of these blue inhalers. So access to blue inhalers is not a cause of death of asthma in the UK. It may be in other parts of the world where they may not be able to get inhalers, but in the UK, the access to the actual blue inhalers was not the cause of death in any of the patients, because even if they were struggling with an asthma attack, they would then still get. What they did find was that there were some people, most people had ordered over 12 of these a year. Some had ordered over 24 a year, and even some of them had ordered over 50 of these within a year. But the common factor of what they thought was the cause of death was the fact that hardly any of them had actually been to see the surgery, or the surgery hadn't actually called them in for an asthma review. They'd not actually been titrated up onto the highest dose of preventive treatment, and there was a missing that healthcare advice over the previous 12 months, where they could have had their asthma treatment improved and their preventative treatment improved. So in asthma, we do need to actually be looking at trying to reduce the inflammation and having something to reduce that inflammation. Right, so I'm just going to be. So Sam says, yeah, Symbicort, salbutamol, and Incruse. So yeah, so Symbicort has a LABA and a corticosteroid, and the Incruse is a LAMA. And then obviously some salbutamol I've just gone. So I will go through those 3 other types in a minute. Yeah. Right, yeah. So after Sean's type 1 diabetes, have I missed something, Tanya? He will have a high glucose. He will have a high glucose for 18 hours after the treatment. Yeah, that's because of the action. It can raise blood sugars, but obviously ensuring that you can breathe is more important than having high blood sugars. But then yes, things need to be done over the next 18. over the next few hours to try and keep that high glucose down. So, hello, Ray. So I've mentioned Ray before. She's a nurse that runs her own channel. She's from the US. Absolutely great if you wanted to follow her on her channel. And that's everybody saying hi to each other. Right. So when it comes to asthma, we really need to try and reduce the allergy component and the inflammation. Now, one of the best things for getting rid of inflammation is corticosteroids. And that is beclomethasone, budesonide, or fluticasone. Now, a lot of people get very nervous about having corticosteroids. They hear the steroid section and worry about all the side effects that are known for steroids, but these are corticosteroids, and they're not the glucocorticosteroids or the anabolic steroids. So steroids come in 3 different types. So obviously we all know anabolic steroids are the ones that bodybuilders use, and they do have severe side effects and issues. Then you have the glucocorticosteroids that are usually used for people that have certain conditions, such as Cushing's and such like, and also can be used to help reduce anaphylaxis, the sort of the hydrocortisone that's used. It's also used in creams as well. And then you have the corticosteroids. And these reduce the inflammation in the lungs, and they get deposited in the lungs and they act locally in the lungs. And actually, the majority of them don't actually have any systemic absorption. So they don't get absorbed into the blood that much. And even when they do get absorbed into the blood, they get flushed out the system and don't really have any long-term side effects. Now, if you end up on the really, really high doses of them, then there is the potential for some long-term side effects, and you will then be warned about them. But for the majority of people on the low dose of the steroid inhalers, there are no long-term side effects. It doesn't get absorbed enough for there to be any problems, especially with the beclomethasone and the budesonide. They are the least absorbed into the system. The fluticasone, it is more potent and it is slightly more absorbed into the system, which is the serotype inhalers. But to get to the high doses where they need to be having them, then you would be warned about it by your healthcare provider. Also, there is in an emergency situation, so say somebody's having an exacerbation of their asthma and is struggling, you may get given prednisolone tablets to take, which is a corticosteroid that's given sort of orally as a tablet. It's quite often given when having a chest infection alongside the antibiotics that prednisolone is given, and that helps reduce the inflammation. And when it's a short course of just up to 5 days, it can be taken for that 5 days and then stopped, and usually with no long-term effects. Some people do end up needing to have a low dose of the orals long-term, and if so, then that's a discussion with the healthcare provider on sort of whether anything needs to be looked at long-term. But for the majority of people, they can get controlled on the steroids. Now, there was the original guidelines 20, 30 years ago was people were to have a blue inhaler, and that was all they were to have to start with. And they would use that, and only if they were using this every single month, every single day, would they actually consider putting in a brown inhaler. The guidelines have moved now from that Asthma Still Kills report and other reports that have happened worldwide. There is now newer guidance coming out where they're actually starting using the steroid inhaler earlier on. And they're called the GINA guidelines. If you were to Google GINA guidelines, you'll see the World Health, it's not World Health Organization, it's the World Health Institute. So, but they've wrote guidelines about using steroids earlier on. And some of their guidelines is, so they'll either give both of these for them to be used at the same time, or you may even be given a combination inhaler that is a LABA and a ICS. So I'm going to explain what the LABA is. So I've just explained that this is a short-acting beta agonist. Well, the LABAs are the long-acting beta agonist. So it's a similar ingredient to the salbutamol that's in here, but it actually lasts for at least 12 hours, or some of them actually last for 24 hours. So it's that same drug that opens up the airways, but it lasts for either 12 hours or 24 hours. And it comes under the names of formoterol, salmeterol, or vilanterol. So again, they end in they all end in EROL, erol. So not like your beta blockers, which are the opposites that end in ol. These end in erol. And so these act in the same way. They open up the airways and give a steroid. So the new guidelines that are coming out is that, so if somebody needs this inhaler more than, once in a blue moon, once a month, once, just very, very occasionally, then that's fine for that. But if they are actually needing it more than, say, once a week or regularly, they should also start using one of these brown inhalers. And there's two ways to do the dosing of that. It could be that it's just using the steroid once a day, and just one dose once a day, or it can be a when required dose. So it can be every time that you've needed to use one of these blue inhalers, you add in a dose of the brown inhaler, which is where the combination inhaler comes in well, which is the Symbicort. I think somebody's already mentioned the Symbicort or the Foster, and they can be used in what they call a smart regime, where because both the drug for opening up your airways in an emergency is there, they can be used during the emergency, but it's also ensuring that the steroid dose is given, especially useful for people that are struggling to have two inhalers, struggling to remember to take the preventer inhaler. Then they just know that they'll get the dose of the steroid at the same time as they're needing their emergency. But so in asthma, you've got the so the corticosteroid, and that is the first mainstay of the preventer. Then to add in to help with the preventer is adding in the long-acting beta agonist, which is the long-acting salbutamol. And the aim of preventer therapy with asthma is for there not to be asthma attacks. That is the be-all and end-all, is to prevent any asthma attacks, to help with that breathing and getting it under control. Because if somebody is continually having to use the blue inhaler more than a couple of times a week, then they are uncontrolled. Going on from needing them, there is another class of drugs called the LAMAs, and this is long-acting muscarinic antagonists, and they also open up the airways, and they are known as the things ending in inium, calidium, acalidium, and glycopyrronium. And yeah, so it can be quite difficult to get those. Realizing that I've missed writing off one of my things in my notes. So. Oh, yeah, and that's it, and tiotropium. I knew there was another one. So they're all ending in the eon. So it's tiotropium, uncalidium, acalidium, and glycopyrronium. I don't know who came up with those names. So these are the long-acting muscarinic antagonists, and they work in a similar way as the beta antagonists in opening up the airways. Oh, so yeah, so Sam, you mentioned the Symbicort. Yeah, Symbicort's lovely. It's a lovely purple colour. That's what we always used to think. People liked their purple flying saucers. It's definitely one of the better ones. And then, yeah, those scientific names will get you. Yeah, I'm sure what they do on purpose, and this is definitely true in inhalers, is that they have these really, really long, complicated generic names for the drugs. And then they come out with nice names for the actual brand. So then that gets all the doctors and nurses and the patients using the brand name version, getting very used to that. And then when other companies come out with cheaper alternatives, which are exactly the same, up to the same standards, they've just not had to pay for the research and development. So they can fetch it out at a much lower price because it was the originator company that paid for all that research and development. They just fetch it out after somebody's done that, and with just making the drug up to the same standard. And then they can fetch it out, and then people will swap over. But they just hope that everybody's got that original brand name in their head. Yeah, so Advar, yeah. And the other thing that is really confusing is that the names of all the brand names are totally different in different countries, which then makes it really hard when trying to find out what the alternative is. So the long-acting muscarinic antagonists, the tiotropium things, now these are used as preventative mainly for COPD and bronchitis and those sort of long-acting, long-term conditions of the lungs where there's been damage to the lungs. Now, there's many things that can cause damage to the lungs. There is just the aging of the lungs, but then there's previous infections and there's previous exposure to dust and chemicals. So things like asbestos, which actually causes, is very significantly named one, asbestosis, but environmental dust, and then obviously the big one, cigarette smoking, which it took years to find this. Cigarette smoking, it's not just the one-off cigarettes, although please don't tell that to teenagers, they need to know not to start. But it is from decades of cigarette smoking continually causing that damage, because you're basically inhaling smoke. And it would be very similar to inhaling smoke if you was to, say, work in somewhere where they're continually burning wood or anything else with those tiny dust particles. So tiny dust particles that are causing the damage in the lungs. Now, smoking also has its other chemicals that cause other problems for the heart and the circulation, but for the lungs, it's the damage by the actual sort of dust particles, those fine particles in there that are causing the damage. When it comes to e-cigarettes and vaping, we know the risk is much lower, but we do also know that there's some black market vapes where the actual droplets in them are not to regulation and cause this thing called popcorn lung, where it's, you know, dodgy black market vapes. So, right. So Cal says, I was born with underdeveloped lungs, grew up around asbestosis, and due to not feeling my body much, I was usually only noticed when I'm sick, and it's really bad, and it seems to be at the lungs always. Yeah. So a lot of premature babies can be developed with underdeveloped lungs. Quite often, if they know a baby's going to be born prematurely, they can give an injection to the mom of steroids to try and get the lungs to sort of develop quicker and sustainable as they can. But yeah, premature babies can have underdeveloped lungs, and in fact a lot of children aged 1 to 5 can have symptoms that look like asthma, but it does resolve once they actually grow their lungs to be big enough. But for sometimes, if they were born with premature lungs and they never got that final development in the last month of in utero, sort of in the womb, then that can cause lifelong problems. Obviously, being around asbestosis is a known risk factor. And I know people freak out about things containing asbestos. Now, it's absolutely fine to have something that contains asbestos. So if they tell you that your garage contains asbestos, don't panic. As long as it's there in a solid form, it's fine. The problem with asbestosis is when the tiny little particles in it get released into the air and breathed in. So if you would decide to get a lump hammer and start destroying your garage that's made of asbestos, that's when the issue would be, which is why it's only the removal of asbestos that actually needs to be done carefully, so that there's not that those tiny particles in the air to be breathed in into the lungs. Yeah, as my dad rightly says, TB scarring, and yes, a lot of people historically have had TB, and it can leave scarring, as well as some other bacterial infections can cause problems and long-term scarring. And as we have found post-COVID, viral infections can lead to scarring. And when they have pneumonia and they can end up with fluid on the lung or collapsed lungs, and they need to get treated, that can cause scarring to go on. So yeah, so Sam says, I think I might have another chest infections. These infections need to be sorted out. So yeah, as I've just said, each time you have a chest infection, you could be causing more scarring. So the earlier that you can get checked out and get it treated. And sometimes it doesn't always, if it is viral, then it obviously antibiotics, it's not going to cure it. But sometimes they will actually just give the steroids to actually help fight off the infection. It just reduces the inflammation that the infection's causing to stop it actually causing damage as you're getting treatment. Oh, 2 months early in the 90s. Oh, well, yeah, 2 months is very young, and that was excellent. Hopefully you had an excellent neonatal unit. And Sam says, my daughter was born 8 weeks and 2 days early. Yeah. We are managing to get much better treatment for premature babies and keeping really tiny babies alive longer. My daughter was only £3 1 ounce when she was born. You would not know that to look at her now at 5'8". And she luckily has no lung problems from that. Yeah, Caldacoda. Yeah, I grew up in a town that had a factory. Yeah, and that is a big problem. Pollution can be a very big problem. We've actually had one of the first cases where the coroner has actually said that the reason that a child has died from asthma was due to pollution. And it was a child that was in London and was continually the fumes of the busy street that she had to walk by to go to and from school every day was continually affecting her asthma, making her asthma worse. And unfortunately, she did die. And it's one of the first times that they've actually sort of put on the coroner's report that the asthma attack was due to the pollution that child could not escape from. And London, although it is one of a fairly bad city for pollution, it's actually nowhere near the worst in the world. There are some really smog cities as well. And it's not also just that. I know we're currently in Reykjavik, they're currently having problems due to the volcano that's happening a few kilometers away from Reykjavik. And at some point last week, the wind was blowing all of the what we call VOG, which is volcanic fog, over Reykjavik and causing breathing problems for a lot of people in Reykjavik. So it's not just man-made pollution, but also it can be other environmental things. So Tanya says asbestosis and lead abatement is extensive and expensive. Yeah, so I know I had to my garage had an asbestos roof, and I wanted my garage making into another room, and I had to pay for my asbestos to be taken away by a proper company. So it was done. Another Sam. Oh, Sam says she was tiny. Yeah, £3 2 ounces. Yeah, they do amazing. The little £2 babies are surviving now. And Cal says, yeah, it was an asbestos factory, so they were making it early in my youth and then destroying it later in my life. Yeah. Demi says, at Tanya, I'm honestly surprised my family doesn't seem to have any lasting consequences of my mother and grandmother growing up in a lead mining country in Wisconsin. I am. Unfortunately, lead can be deadly poisonous. It's one of those sort of metallic ingredients that your body can't actually flush out of the system. And it can cause, it can deposit in the brain and cause different types of psychoses and such like. Okay, so your grandmother's may have been related, yeah. So Demi says, it's probably a lot if the town is literally called Lead Mine. Yeah. Yeah. So as we were talking about, so the both with asthma and with COPD, asthma it needs to be kept under control all the time, because to try and reduce the amount of times that asthma attacks happen, keeping that inflammation under control. Now, this can also be done because it can be sort of autoimmune. It can be related to allergies and the immune system due to allergies being attacked. So there are some other things that can be used to treat asthma when it is induced by allergies. And there is a oral medication, a tablet that's called Montelukast, and it actually affects on the immune allergy pathways and can be very useful. It's mainly useful in children. It seems to work a lot better for children. It does work in some adults, but it's only certain adults where the asthma is very related to their allergies. They potentially have nasal polyps, and they're potentially those that are allergic to aspirin. So anybody that's allergic to aspirin, probably Montelukast will work really well for them. Never known why, but it's a useful thing. Now, Montelukast, in the most part, doesn't have any side effects. However, it has come and been aware that there's been a health alert around the fact that from the yellow card system, where they report adverse effects, that there is the very rare adverse effects that Montelukast can affect psychiatric health with suicide and psychosis. So that is something to bear in mind with Montelukast. And somebody who maybe has a history of sort of mental illness, or just to keep an eye if there is any mental illness and they're on Montelukast, to see whether that's a factor. Cal says it's cool to see the drop in crime rates when the lead was getting banned. Yeah, because the lead does affect the brain. So, and yeah, causing problems. Right, Cal says now we need to get rid of microplastics and then we'll find the next thing. Yeah, there's all we're continually learning. The more things that have been created, we think we've created something to be of benefit, and then we find out years down the line that the side effects, because a lot of the time it's not until we have long-term data that we can actually find out the problems. As you'll probably all know, and I am going to make things, the inhalers originally were made using CFCs, or chlorofluorocarbons, which were a massive and amazing invention of an inert gas that could be used for so many different things, but in fridges, in propellants. And we were using it for years thinking, wow, this is amazing. And then we realized that there was this big, massive hole in the ozone layer that we'd created. But luckily, the ozone layer is repairing. We've taken CFCs out of everything. And there was a big problem with inhalers when we changed from having CFC containing propellants to non-CFC, so the CFC-free propellants. And it made the taste of the inhalers taste a lot less, and or taste different, and that caused a lot of people to think that they weren't working. And we've also now got a similar thing of the fact that they're really, really trying to, for the NHS and probably elsewhere in the world, they're trying to reduce carbon emissions in the NHS. And one of the things they're trying to reduce carbon emissions from is the use of plastics and propellants. So inhalers have really got hit by the fact that they're trying to reduce the carbon footprint of inhalers. So there is a move to change over to the dry powder inhalers and to actually reduce the propellant in these inhalers. Now, you will all see that I am very, very lucky. You can see it there. I've got a Ventolin. I've got a Ventolin this time. The last two times I've had a Salamol. And this has been a query that we've got recently. Is a lot of people have found that the Salamol, they have changed the formulation of it to try and reduce its carbon footprint, which has reduced the amount of propellant in it. And then, although technically it is delivering the same dose each time, it really doesn't feel like it does. It really doesn't. When you press it and the propellant comes out, really is not the same amount of propellant as those previously is. And people just really don't feel as though it's working. And also they are blocking up easier as well. Yeah, so I might, you have to tell me if I pronounce this wrong. Is it Aaliyah? Is that how you pronounce your name? You said, yeah, I miss the old inhalers since they could actually spray faster and seem to work better for me. And yeah, you love your Ventolin. And all I would have to say is, yes, each one does provide the same amount, but it feels a lot different. And I would say always try using one of these. This is also very useful because when you're using an inhaler and you're trying to do it thing, you can't always see whether it's done the dose. Whereas spraying it into here, you can see the actual dose is happening. Okay, so Demi says, does the amount of propellant in an inhaler really account for the large carbon footprint? I could get political here, but yes, there is some carbon. There is some carbon footprint to it. But I really do think there's bigger fish that we can fry rather than taking it away from a medical device that's actually essential for many people. There is definitely bigger fish to fry with carbon footprints of other countries that are probably putting a lot more methane and carbon dioxide into the air than these. Now, I would say that I do think there should be a move away of the propellant inhalers to the dry powder inhalers. Not anything to do with carbon footprint, but the fact that the dry powder inhalers do actually deposit in the lungs a lot better than these. Because when you press these, there's the tendency for it to hit the back of your throat and deposit on your throat, and then you end up swallowing it into your stomach. With the dry powders, there's better coordination with actually having to suck it in. More of the dose can end up being lower in the lungs. So the dry powders can be more beneficial, especially for people with COPD. However, as I always say, the best medicine is the one that somebody will use. So the best inhaler is the one that somebody will use, the one that they feel is using, the one that they can consistently use, the one that they can remember to use. And one of the big problems that we've had recently is we used to have inhalers where people would have 2 or 3 inhalers. They would need 2 puff twice a day of each of them. That's quite a lot of doses. And we all thought that changing people off that onto these brand new inhalers where literally you just have an inhaler, all 3 doses last all in that one inhaler, all 3 doses last the whole day. You just need to take 1 dose or 2 doses of one inhaler, and that's it, and it provides all your thing. And we thought that that's much more convenient. People will love that. But we're actually finding after trying to swap people onto these, they don't. Because you've got the one shot at it, if you don't quite coordinate that one shot right, or there's other problems, then you don't get that one dose, and then you're stuffed for 24 hours. And yeah, they just don't feel it's of benefit. So we've had quite a lot of patients where we've changed them onto the triple inhalers to have it all coordinated into one dose, and they've ended up going back onto separate inhalers because there's more consistency of them being able to get the dose. Right. All right, so Demi says, it reminds me of telling people to turn their tap off while brushing their teeth to save water while ignoring the wasteful water use of companies like Nestle. Yeah, I'm a Cadbury's girl, all I can say on that one. But yeah, I would say turn off the tap while you're brushing your teeth to save on your water bill if you've got a water meter. If you haven't got a water meter. Oh, Crystal, see you walking past. That was my daughter. But yeah, and again. But yeah, you can, we can all do our best to not waste water so that we've got it, the reservoirs don't dehydrate, run low. So I would say if you are in a water pipe ban, to not use, to do that, a hose pipe ban. Yeah, they are bigger fish to fry. So Sam says, do spacers work with Symbicort and in cruise inhalers? No, they don't. These only actually use for the MDIs. The Symbicort is a dry powder, so it actually, you click it to release the powder and then you suck the powder in. And so it's actually the action of your suction that actually pulls the drug in. Now, I would always say for all the inhalers, if you don't feel as though they're working or you're not getting the benefit, have a word with your nurse or pharmacist and actually get your inhaler technique actually checked. So have the nurse or the pharmacist actually watch how you use it and tell you whether you are using it correctly or not. Now, for the dry powders, nurses quite often have a device that's basically the opposite of a peak flow meter. So a peak flow meter, a lot of asthmatics will have and use when they go to the nurse, which is you puff as hard as you can, moves the little indicator along, and it lets you know sort of how much lung capacity you've got. Well, they have an opposite one where you suck in, and it'll pull the little dial along to see the strength of your suction, and it'll tell you whether you're able to use a dry powder and which one of the different dry powder devices that you're going to be best using, that you will get the most out of. So I would always think is that if you can. Now, I do prefer the dry powders because they do get into your lungs. And I think somebody, yes, Ilea has said, I've been told I'm supposed to swish my mouth with water after because of thrush. Should I be spitting out the rinse? Right. So yeah, so this comes from any of the inhaled corticosteroids. So the fluticasone, beclomethasone, or budesonide, or any of the inhalers that contains that. Now, if that comes in an MDI, then one way to reduce the amount of thrush is to use the spacer, because any of the depositing will happen in the device and you actually don't get as much deposited on your mouth. But even if you're using a aero chamber or a dry powder, there will be a certain amount that gets deposited around your mouth. And yeah, so it is good to squish your mouth out with water and maybe even brush your teeth and then rinsing it out. Now, whether you swish your mouth and swallow or swish your mouth and spit out doesn't particularly make too much difference, because you don't actually absorb it systemically through your stomach. Those three drugs aren't actually very well absorbed through the stomach, luckily. So even if you do swallow it, you don't really absorb much in. In fact, they actually use the beclomethasone, the budesonide. They actually use them for treating in massive doses in tablets to treat Crohn's and colitis, and they act just locally in the intestines and they don't get absorbed all that much. To actually get a drug, to get a corticosteroid that's actually absorbed, you need to be using hydrocortisone or prednisolone, are the two that actually get absorbed into the bloodstream. Okay, so hello, Make Me Smile. And Make Me Smile says, can you outgrow asthma and then it come back when you start smoking? Right, so I did mention earlier that children can have asthma and then, can seem to have asthma from the ages of sort of 0 to 5 and then outgrow it as their lungs develop. You can also have asthma and it be very well controlled if you're not actually getting any of the allergens or triggers actually around. And then if you actually then start getting exposed to your triggers, then your asthma can return and get worse. And obviously, yeah, smoking can worsen asthma. So it's not the fact that you outgrew the asthma and then it came back. It's more the fact that your asthma was under control and not happening. And then when you actually start smoking, you're actually introducing something that is a trigger for your asthma. So yeah, asthma resolved isn't really something that actually happens. If you've got asthma, you're always at risk of asthma being there. So even people that think that they're actually very well controlled with their asthma or haven't had an asthma attack for a long time, if they've ever had an asthma attack that's caused them to struggle to breathe, then they should always keep their reliever on them, just in case they ever come across a trigger that causes their asthma to suddenly happen. And as I speak, one of the triggers can be cats. I've just had a cat wander through here. So Aliyah says, smoking can hurt your lungs and is a cause of COPD. Smoking is causing your lung problems and breathing issues come from it. My dad was a smoker for 40 years and now has COPD and struggles to breathe. Yeah, so smoking, can be a risk factor for COPD. It's not the only cause of COPD, and you can not smoke and it happens. Also, some people can smoke and it never affects their lungs. It's just what we now have is a risk factor. Obviously, I would always encourage anybody who is smoking, if they can reduce the amount they smoke, then it is overall better for their health. If they can't stop smoking, then moving on to a safer alternative like e-cigarettes can really help as well. But you've also got to have your risk balance of your life. If smoking is the only way that you can actually cope with anxiety and other issues that are in your life, then it may not be the point where you actually want to try and stop smoking. Also, we've had cases as well where somebody is near enough end of life. There are really severe COPD, and then we've still got somebody, some nurse or health professional, come along and tell them to stop smoking, and we're like, really? There's no point right now. You might as well let them enjoy their last section of their life rather than putting through all the stress and anxiety. It is a choice. People are to know the risk factors, and then also it's their choice on whether they want to reduce those specific risk factors or not. So then I was saying that, so with asthmatics, to reduce the allergy symptoms. Now, there has been some new developments, and I've talked in migraines about that we have now biologicals that can treat migraine. We now have biologicals that can treat rheumatoid arthritis and other autoimmune conditions. Now, biologicals are medicines are actually made up of proteins. So they take peptides and they create proteins, and they have there's sort of a protein molecule that actually acts in protein as proteins would in the body, actually on protein receptors. And a lot of these work on our white blood cells, our immune system, and sort of attach them on there. So obviously with some asthmatics, there is an allergic component where the immune system is responding and causing inflammation. And they have now actually created a couple of biological medications that actually can treat asthma if it is an allergy-induced asthma. And it's dupilumab, which is called Dupixent, and olailumab. I can't remember the brand name of that one. It's probably a lot easier to say, so I ought to learn it. And those two, they are also used to treat eczema. And as I was saying right at the beginning, somebody who is asthmatic might also have eczema. And it is quite sort of thing that interesting that, yes, the same biological, it acts on the same pathway in asthma as eczema. So somebody who has both asthma and eczema are much more likely to respond to this drug because it seemed to work on both. So it has been great that we now do actually have this biological for those people that what we call brittle asthmatics, where, we just can't get them under control no matter you know, we've increased up to all the different oral medication, all the different inhaled medication, and they just can't seem to get it under control. People can start these biologicals and really reduce down the amount of steroids they need. So quite often these brittle asthmatics have ended up on long-term oral steroids, having all the side effects of that. So the weight gain, the fluid gain, the moon face, the risk of osteoporosis, and they can actually be treated with these biologicals. Now, they are injections that need to be given each week, but, you know, it's, you know, we're getting more and more of these. So I'm quite excited that we can get more people really treated, these brittle asthmatics that are high risk. Unfortunately, when it comes to COPD, we have no magic no magic biologicals for that yet. It is a deterioration of the lung function, and so it is important with them that we try and maintain as much lung function as we can. So they will be given LAMAs, which was the tiotropium, or the EONs, and the LABAs, the long-acting opening up ones, the formoterol, vinetrol, and salmeterol. Now, we don't tend to use the inhaled corticosteroids as much in COPD because there isn't always an inflammatory component. So it's only those that have had a previous asthma diagnosis or actually are showing that they actually have high levels of white blood cells going around, showing that there is some inflammation. So something is causing some inflammation. They might be added on with the fluticasone, beclomethasone, or budesonide in and add those in. Also, we do have to watch because obviously somebody with COPD is at higher risk of getting chest infections. So it can be worth them having a discussion with their GP about how they can easily access chest antibiotics if they do get a chest infection. It's always something worth asking. Also with COPD, not really with asthma, but with COPD, there can quite often be a lot of mucus made. So we all know about phlegm and mucus, that horrid stuff that we get when we've got a chest infection or a cold. And that can quite often sort of be there on the chest, causing irritation, causing problems. The inhalers that open up the airways will help with the opening up the airways so that you can actually cough that mucus up and out. And it is always best to cough up that mucus up and out. People might think having a cough suppressant to actually stop the coughing can actually be a bad thing, because we're actually needing that phlegm and mucus out, because that's where bacteria can breed and can cause the infection. So coughing it up and out is best. Some people used to use a lot of nebules and saline nebules and such like to help with helping that mucus thin and get excreted. But 10 minutes on a nebulizer can be equivalent to just actually having a glass of water. So actually just drinking enough fluid to help keep yourself hydrated can help keep that mucus thin enough to actually cough up and out. So as we always say, when somebody is ill and they've got a cough and a cold, we say, drink plenty of fluids, take some paracetamol. Well, that drink plenty of fluids, there is a reason behind that. It does actually help clear the fluid up and out. Although if you are struggling, another good thing to do is steam inhalations. So, but it doesn't necessarily need to be a steam inhalation put in your head. You can just have a nice hot bath. That can help. The steam of having a hot bath or a hot shower can help loosen that mucus and help cough it up. And there is also some medications that can help loosen the mucus and cough it up. One's called carbocysteine, and that has historically always been used for cystic fibrosis. So, yeah, so cystic fibrosis is a whole different condition that is very specialised. I'm not going to cover that here, but they quite often end up using inhalers and such medication. So, Eloise says, I agree about end of life. Yeah, when people are getting to end of life, we've got to learn to live life, and we've got to try and make sure that people enjoy and do what they can at the end of their life. Don't need to make things more miserable for people. So does weight affect COPD? No, it's not a risk factor. It doesn't particularly itself affect COPD. However, there is some weight can affect another related condition, which is sleep apnea. So sleep apnea is where you stop breathing when you're sleeping. And it's usually because you're laid down, and it can be due to sort of the weight around your neck area, causing a constriction of the windpipe, the trachea, and also other problems. It can also be due to sort of the structures at the back of the throat and the nose that cause the blockage, and quite often they need to actually have CPAP machines, which is a mask that you wear that pumps oxygen and forces air to keep the airways open. But yeah, sleep apnea, which can be caused by weight, is to do with the upper airways, whereas COPD is to do with the lower airways. And now actual obesity doesn't actually cause problems with COPD. Now, obesity can cause lots of other problems, and could other health conditions could contribute, but in itself, it's not actually a risk factor. So I think I've covered all the drugs that I've written down about that are in inhalers. So Cal says, one of my co-workers has extreme sleep apnea and complains about the machine all the time. Yeah, the machine is not comfortable. It is not an easy way of sleeping. So it's supposed to help you sleep because it keeps your airways open, so stops you stop breathing during the night. But yeah, it's not conducive to sleep to have this big mask. Now, there has been some developments in creating a nicer machine that literally just fits on the nose. That's a lot nicer. And there is also some injections that are being, and I can't quite understand how these injections work. I'm going to have to work out the pharmacology behind it to help treat sleep apnea. But yeah, one of the best treatments of sleep apnea is to try and get rid of that the weight that's round. And they have even used sort of fat dissolving injections to dissolve the fat around the neck area, though I'm not sure that that's actually got any evidence. Okay, so he harassed the hospital until he gave him one with the tube at the top of his head. Yeah, I'm not too sure about the different designs of sleep apnea ones, other than, yeah, they are developing them. So Demi says, my mum complains about my dad's CPAP machine way more than he does. Well, yeah, it probably is more annoying for anybody who's trying to sleep. The only thing I could suggest for that would be a second bedroom. Yeah, says it's loud and she can't sleep because of the noise. Well, I don't think that would actually be a problem for my mum and dad. They sleep in shifts, so anyway. One's either asleep or the other one's asleep. They go in sleep shifts. Yeah. So he said, yeah, shut your bedroom because of it. Yeah. Right. So yeah, I think I've covered all the different types of inhaler. Hopefully I've covered a bit about inhaler technique. Now it's a bit hard to do inhaler technique because although I only looked two to show you that are mine, I can't show you all the different devices, but I would always suggest getting your inhaler technique checked by a nurse or a pharmacist. In the UK, when you have your yearly checkup with the asthma nurse or the COPD nurse, they are supposed to check inhaler technique. I'm not convinced it always happens, probably because, you know, time restraints and such like. So I would always say take your inhaler along and get them to double check, because even somebody that had brilliant technique in the first place, when they first started using it, we all get into bad routines. We all get into bad ways of doing it. bit like driving. We all learn to sort of pass our test. We know the perfect way of driving, and then we all slip into bad habits. So yeah, it's always worth getting your technique. But thank you. It's been a great live stream again. It's great to have you all here. Looks like I've had about sort of 11 people still on. So hopefully the settings look good. Yeah, let me know if you've got any ideas for my next live stream. And I do really need to get on top of actually doing some recording of videos. But yeah, it has been a bit crazy with extra work that I've tended to in an evening. My brain's just wants to relax. Oh, that's great. So my dad says, Dad got a review with a nice nurse just after your birthday. Yes, it is always good to have a nice nurse. And I would say if you ever have a problem with a nurse or a doctor, you can always ask to see a different person. And if you're continually having problems, you can put in a complaint. Because yeah, we should be getting proper full reviews from our doctors and nurses. So Mr. Raven Jalab says thank you, very interesting. It is very interesting, inhalers. There's so many different things about medications that are interesting. COPD and asthma isn't my specialist subject until I decided to develop adult onset asthma, and I suddenly did some research. And also I have been doing quite a lot of work helping my GP surgeries highlight patients that have been missed, because it's very easy to highlight patients that are overusing medication, demanding medication, the ones that are always there. It's very easy to sort them out, but it's very hard to find those patients that are struggling. And so I did some sort of computer searches. So you can search on a GP computer system for different subsets of patients. So I created a search that found people that were collecting 5 or more of their reliever inhalers in a year, but hadn't actually been given a preventer inhaler or hadn't collected more than 3 of their preventer inhalers in a year. Because it's very hard. The doctors and nurses don't always have the time during a review to actually look back over the full record. So this way I could highlight them, put a warning on the screen for the doctors and nurses so that they knew about these patients, and provide a list for them to work through when actually call those patients that were struggling. So yeah. Thank you, Sam, for always turning up. I really appreciate you coming on and providing your input. I appreciate you all. So thank you very much. I've kept it under an hour and a half. I might be going out and giving my daughter a driving lesson now. Hopefully car park's empty. Oh, I am a busy pharmacist at the moment. At the moment, I don't even know what my job role is. I'm stepping up to do what my boss's job was while we're restructuring and then working out how we're actually going to do. My specialist areas are gastroenterology, ophthalmology, and dermatology, anything that tends to use the biologicals. I've also special interest in high cost drugs, so all the really expensive biologicals and anything that consultants want to use, and then the passing out of expensive medications and high risk medications that consultants are wanting out to GP practices, which ones can and can't be. So that's my specialist subject there. But yeah, whether I get to continue doing that in our new restructuring, I've no idea. Just have to see how it goes. So thank you all, and I'll end the stream now. See you later. Put a comment in the comments if you've got any ideas for future.